Hello everyone, welcome back. Today I'll be covering regarding osteoporotic vertebral fracture (OVF), a part 1 video. In this video, I will start with a background of osteoporosis. How does spine change with age? How does osteoporosis impact the aging spine? Acute symptomatic vertebral body fracture. Osteoporotic fracture evaluated clinically and radiologically. Conventional radiograph findings, the role of CT scan in osteoporotic fracture, and the role of MRI in osteoporotic fracture. I hope this video will help you. Now let's get started. Background. Osteoporosis is characterized by thin, fragile bones and may result in minimal trauma fractures of the vertebral body. They can cause severe pain and disability due to acute vertebral fractures. In contrast, osteoporotic vertebral compression fracture that occurs slowly over time is often asymptomatic. It became apparent because of the height loss or kyphosis. How does the spine change with age? Normal aging brings gradual modification in the overall sagittal balance with compensations that keep the center of gravity over the pelvis and preserve a horizontal alignment. Certain local parameters will be altered, leading to compensatory mechanism. Lumbar lordosis is the weak point, as it concentrates most of the physiological and pathological modifications in the lumbar area. A gradual reduction in lumbar lordosis has been observed around 70 years of age, inducing an increase of trunk forward flexion followed by pelvic retroversion and increased cervical lordosis, corresponding to compensatory mechanism. Hasegawa et al. Found an increase in thoracic kyphosis. When the compensatory mechanisms are overwhelmed, a pathological cascade takes hold with the knee flexion that alters the gait. This whole spine X-ray shows the compensatory mechanism. There is an increase in cervical lordosis, increase in thoracic kyphosis, with the knee in flexion. There is a positive sagittal balance. How does osteoporosis impact the aging spine? The occurrence of an osteoporotic fracture on an aging spine can cause worsening of the sagittal alignment with appearance of secondary traumatic kyphosis, aggravating the anterior malalignment, leading to a risk of fracture cascade and increasing the risk of non-union. From a surgical perspective, confirmed osteoporosis means that the treatment must be chosen carefully to limit the risk of complications, adjacent vertebral body fracture, instrumentation failure, poor implant anchoring. For acute symptomatic vertebral body fractures, there is often no history of preceding trauma. The typical patient presents with acute back pain after sudden bending, coughing, and lifting. Sometimes minor trauma, such as going over a speed bump, may precipitate a fracture. The pain is usually well localized to the midline spine, but often radiates to the legs, can be due to rectopulse bone fragment. The pain from a vertebral compression fracture is variable in quality and may be sharp or dull. Sitting, spine extension, Valsalva maneuver, and movement often aggravate the pain and may be accompanied by muscle spasm. Sleep may disturb by pain. On physical examination, the patient may experience pain upon palpation of corresponding spinous process and paravertebral structures. How is an osteoporotic fracture evaluated clinically and radiologically? Osteoporotic vertebral fractures occur frequently even though some are likely missed. This lesion can have serious consequences, that is chronic pain, spinal deformity in kyphosis, potential but rare neurological deficit that requires special attention. What is the clinical evaluation of a potential osteoporotic fracture? This is the first challenge because the symptoms may be non-specific and the clinical examination inconclusive. A traumatic event is not inevitably found. The most common sign, around 85%, is back pain. While the neurological signs are rare, they must not be missed. What is the radiological evaluation of a potential osteoporotic fracture? AP, anterior posterior and lateral views generated by conventional radiography with the patient standing. Osteoporotic fractures described by Gannett, the shape of the fracture as wedge, biconcave or crush, and evaluated its severity based on the degree of bone deformity, whether it is mild, moderate, and/or severe. This figure illustrates the fracture pattern. The shape either is in wedge shape, biconcave, or crush in nature. Radiographs are also used to evaluate the area around the fracture and provide information about the location, number of vertebrae damaged, condition of the end plate and pedicles, the vertebral height, the bone trabeculae, or presence of concurrent spinal deformity. This X-ray shows the pattern of the fracture in an osteoporotic patient. The wedge shape and the biconcave shape. What is the role of CT scan in osteoporotic fracture? It's a bit difficult to distinguish a recent fracture from a chronic one and may miss fracture at multiple levels. CT scan has higher cost and significant radiation. CT scan is used for planning a surgical procedure based on degree of deformity due to the fracture and the quality of the surrounding bone. Planning for cementoplasty, posterior fixation, based on the length of construct, the size of implants, whether fenestrated use can be used, or combination of techniques. Viewing the bone trabeculae provides information about the cortical and cancellous bone and on the paravertebral and epidural spaces. This figure illustrates a spinal computed tomography CT scan indicating a multiple vertebral compression fracture, particularly in T10 and L1. The coronal CT images showing a severe osteoporosis and osteolytic expansile lesions in T11. B. The sagittal CT images showing multiple severe vertebral fractures and cortical bone thinning. Role of MRI in osteoporotic fracture. MRI helps in providing diagnostic and prognostic information, the differential diagnosis, residual pain prognosis, and therapeutic information, the number of vertebrae to treat, whether additional release procedure is required. It helps in analyzing a neurological features that may require decompression and to make differential diagnosis, especially in patients who are being treated for cancer. This MRI figure shows that L1 and L2 is an old fracture, but the L4 is a recent fracture. Hyperintensity on stir sequences confirms that the fracture is recent, that is within the 3 months. The presence of a diffuse T1 weighted hypointense signal in the vertebral body is associated with a risk of residual pain at 6 months post-fracture, and the presence of hyperintensity on T2 weighted sequence and or the concurrent presence of chronic fractures are independent factors for back pain. Hyperintensity or damage in the posterior wall are independent risk factors for delayed union. This figure illustrates the type of examination in MRI that shows or suggestive of benign condition versus the malignant condition. In the MRI morphology, for benign condition, there is a normal posterior element signal, there is a retropulse bone fragments, and additional benign vertebral compression fractures. But for malignant condition, there will be an abnormal posterior element signal, there is an epidural or paravertebral soft tissue mass, expanded posterior vertebral contour, and metastasis in other vertebrae. For the MRI signal and enhancement patterns, for the benign, there is a preserved normal marrow signal, there is a regular margins, linear horizontal hypointense T1 or T2 band, there is a fluid signal, and normal enhancement relative to adjacent vertebrae. For all malignant features, there will be a geographic replacement of normal marrow signal, irregular margins, increased enhancements relative to adjacent vertebrae. Yay! We have reached to the end of this video. I hope you have learned something. See you in the next one. Take care and bye.